So when you go to clinical and you see someone with excessive secretion or bronchospasm, physiologically you won't see the airway resistance, but you'll understand that the patient is experiencing airway resistance. Got it? Okay, so this is a bronchus, or this is a lumen, or a patent lumen, or a intact bronchus airway, right? My finger's going through. See it? Breathing easy. Laminar flow. Right? Everybody see that?
Yes.
Laminar flow. All right. Now what's happening is you've got a patient, for whatever reason, let's say asthmatic. They are now experiencing bronchospasms, or they have excessive secretion. See this second one here? See those secretions sitting in that airway? That's decreased the diameter or the lumen of the airway. And Poussin's law is saying anytime you have a decrease in laminar flow or decrease in the lumen, it's going to increase either the pressure or decrease the flow. So basically all this is saying, as a patient's airway is clogged full of secretion, it's going to decrease flow that goes through the airway. Does that make sense?
Yes.
All right. So on inspiration, the main muscle is what?
Diaphragm.
Diaphragm. We still have our diaphragm to breathe, but let's take an asthmatic or a COPD patient that has excessive secretion. What you're going to see, because they have an obstructive disease, expiration, if we inhale with our diaphragm, what happens on expiration? It's passive. But now we got excessive secretions in the airway, right? So therefore, if they have asthma or COPD, if they have these excessive secretions, the first thing we're going to see is we're going to begin to see them struggle with expiration. Okay? And that means they can't get the air out. Okay? Everybody with me? Yes.
Yeah, so COPD can inhale, but they can't exhale good?
Absolutely. Asthmatics can inhale, but they can't exhale. So they have air trapping. And so where does that air trapping remain? In the lungs. So in the lungs, it's going to be harder for them to exhale. And the reason it's harder for them to exhale because expiration is passive, and now they can't get the air through this lumen with these excessive secretions. Before I could do this. Now, see, I can't even get my baby finger through here because these secretions are sitting in the airway. Okay? So what does that mean? If they can't get the air out, the next breath that they try to take in is going to be the same thing. They're going to struggle trying to get air through this decreased diameter or this airway full of secretion, right? So we're not going to see an increase in airway resistance. That's what that is. But we're going to see the patient then struggle exhaling first. So if it's asthmatic, you'll hear wheezing on expiration first. Got it? If it's an asthmatic, they'll wheeze on expiration first. And then if they don't get to us soon enough, then we're going to hear wheezing on inspiration. So Poussin's law is just simply saying increase in airway resistance anytime you have excessive secretions or bronchospasm. All right? And then comparing our laminar or smooth flow, a patent bronchus. Now, this one is not only full of secretions, but you can see the diameter has markedly decreased because of bronchospasm. See the difference between these two? This is the laminar flow. This is bronchospasm and excessive secretion sitting in there. Poussin says if the diameter of this airway decreases, it's going to increase airway resistance. That's all he's saying. And we're not going to see an increase in airway resistance. We're going to see a patient have a problem exhaling. And initially, we're here wheezing if it's asthma on expiration, because expiration is passive. So patients with obstructive diseases have a problem exhaling. That's where initially we're going to see the problem. If they inhale, they should be able to exhale, but they don't exhale so good. And then if we don't get to them soon enough, then we're going to see and observe them having a problem on inspiration. And you shouldn't have a problem on inspiration because you got your diaphragm. But you will see that increased work of breathing, or what we call shortness of breath. Yes, ma'am? That's when you'll see accessory muscles on expiration with COPD patients and asthma patients. Patients with obstructive diseases have problems exhaling. They can't get the air out. They can't get the air out. Expiration is passive. It should be easy, but it's not. So with your asthmatic, initially you will hear them wheezing on expiration. Prolonged expiration. It's going to take them longer to get it out, and actually they never get it out. And if that ensues, then we're going to see they're going to begin to struggle on inspiration. So initially, asthmatics will use accessory muscles on expiration, and then they'll struggle, and then they'll start using accessory muscles on inspiration. And that's worse. We can expect it on expiration, and we'll get to them. But if we can't get to them, or they don't come in or whatever, then they'll have accessory muscle use both on inspiration and expiration. So this is all Poussin's law was saying. You have laminar flow, which is good. You have bronchospasms or excessive secretion. It's going to decrease flow. And you're going to see the patient struggle. Okay? So I'll pass this around. I saw a hand over here, Catherine.
I'm thinking if they can't exhale correctly, is that what makes them a CO2 retainer?
Part of it. What makes them a CO2 retainer is because they've lost the elasticity in their lungs. Compliance is the ability of the lungs to stretch on inspiration.
Right.
Elastic recoil is the ability to return to its natural shape.
Okay.
They've lost their elastic recoil because of air traffic. So their lungs can't return to its natural shape.
Okay.
And so they retain CO2 because they can't exhale.
Okay. Okay.
Make sense?
Yeah, because of those. Okay.
Yes, ma'am.
I don't know if this is connected or not, but a person that's a CO2 retainer, do they have a larger dead space in the alveoli, or is there such thing as more dead space?
They have an increase in physiological dead space, but it also causes a shunt. Yes. Mm-hmm. If they have air traffic. All CO2 retainers, not all COPD patients have air trapping. It's the CO2 retainers that have the air trapping.
And a larger dead space.
Yes, an increase in physiological dead space. We all have anatomical dead space. But anytime your dead space increases beyond anatomical dead space, that's physiological dead space. So a CO2 retainer has physiological dead space. Yes.
So let's have a mucolytic site and the diagnosis.
Yes. Yes. If it's an asthmatic, you don't need the mucolytic. That'll kill an asthmatic. But if it's a CO2 retainer, they possibly need the beta-2 agonist. I wouldn't even give them a mucolytic. I probably would give them an anti-inflammatory drug. Because mucolytics, the side effect of mucolytics is bronchospasm.
So in the bronchial blockage, and is always going to be...
Repeat.
I said in the bronchial, we're talking about COPD or asthmatic, most of the things that are blocking a bronchial are going to be secretions. It's not going to be scarring, because I heard somebody say...
Oh, no.
Scarring from COPD, which doesn't relate to that at all, right?
That's later on, that's bronchiectasis. That's
when
further down the line.
That's just like continual damage and then scars there, okay. So it's not, in normal status, it's just specifically different types of secretions that are causing the blockage that thicken or... then we're obviously trying to break that up. They
Yeah.
get thickener loose. Normally it's thin and it cleans itself out. Then
So the whole point is, I want you to understand, in respiratory care, this is Kathy Miller speaking, our responsibility, again, I said it, is to maintain a patent airway. And when an airway has excessive secretions in it, that's not a patent airway. So anytime an airway has excessive secretions in it, it's going to interfere with either inspiration or expiration. But initially, it interferes with expiration because expiration is passive. The thought is, or physiologically, if we inhale, we should be able to exhale, breathing easy. But if you've got excessive secretion sitting there, exhalation is not so easy. And when a patient has a difficult time exhaling, that's classified as obstructive disease. That's COPD, that's emphysema, that's bronchitis. Together, they make up COPD and asthma. Asthma is chronic, but it's reversible. COPD is not. Does it make sense? And so that's a very good example. What you have here is Poussin's law. The smaller the airway, or the more secretions in the airway, it's going to increase airway resistance. Okay? So he's saying that flow will decrease 16 times. You bet your buddy. So what does that mean for a patient? Increase in airway resistance, and we'll see them with the increased work of breathing. That's all he's saying. Got it? Yeah. All right. So on your board, they're not going to ask you about Poussin's law, but you can bet your sweet bippy they're going to ask you about airway resistance, one way or another. Maybe a patient on mechanical ventilation, I don't know, whatever. But we understand an increase in airway resistance, right? Just like when you assess a patient, you're not going to see peripheral chemoreceptors, but you're going to see the manifestations of it. You're going to assess the patient and observe the increase in heart rate. You're going to assess the patient and observe tachypnea or hyperpnea. You're not going to see pulmonary vasoconstriction, but you'll see a patient perhaps confused or diaphoretic. You'll put a pulse ox on their finger, and you may see the pulse ox decrease below normal. You do a blood gas, and you see their PO2. All of these are clinical manifestations of activation of those peripheral chemoreceptors. Okay? So back to airway resistance. You won't physically to be able to see airway resistance, but you'll see the manifestations of it. Patient will have an increased work of breathing. Patient will be short of breath. You will hear wheezing. You will hear rhonchi, which means excessive secretion. All right? All right. So again, obstructive disease patients initially have a problem with exhaling. They can get the air in, but they can't get it out because expiration is passive. But it's passive, they've got a resistance there. They've got these excessive secretions there, or they have bronchospasms there, and it makes it more difficult for them to exhale. So with obstructive disease patients, initially the struggle will be on expiration. Does that make sense? All right. So the second-year students got that model, I think, from VA. I don't know who's at VA. Somebody's at VA. And they let them use this. And I said, oh, can I use this for the first-year students? The open house they had Friday night was absolutely phenomenal. It just blew my mind away, what they had done. And I asked them for this. I said, can I have this? And they said, yeah. You know, so there you go. It doesn't have it on there, but you can write it on there. That's Poussin's law sitting right in front of you. And what is this talking about? Airway resistance. And if a patient has an increase in airway resistance, they cannot adequately exhale, so therefore their ventilation is altered because expiration is part of ventilation, right? And so if they can't exhale, they have air trapping, right? And what is in the gas we exhale on expiration? CO2. So that's how we get CO2 retainers. They can't exhale. So the gas remains stuck in their lungs, and that's called air trapping. Does that make sense?
Yeah.
And you may also hear a term called hyperinflation. CO2 retainers' lungs are hyperinflated. What does that mean? Well, like Letitia said, it's dead space. It's physiological dead space. What kind of gas is in the air that we exhale? CO2. So that's why they're CO2 retainers. We assess that CO2 is greater than normal, so then we can say it's hypercapnic or they're hypoventilating. Does that make sense?
Yeah.
All right. So in detail, respiratory therapists understand that we can see what's going on. We know conditions where the problem is initially inspiration, and then now you're learning conditions, particularly COPD or CO2 retainers, because not all COPD patients are CO2 retainers, but specifically CO2 retainers and asthmatics when they're having an acute exacerbation of asthma, they can't exhale because they've got to exhale through this junk in their airway. And so our bronchodilator therapy, or whatever means necessary that we facilitate and promote a productive cough, will assist them. Does that make sense? All right. Any questions? Yes, sir.
I've heard you say before, Ms. Miller, that not all COPD sufferers are CO2 retainers. Does it have to do with the stage of COPD? Okay.
It's 4 stages.
Okay.
Stage 3 and 4 are CO2 retainers.
So stage 1 and 2 would still be somewhat normal?
Stage 1 and 2, no, not normal, but they're not CO2 retainers.
Okay.
Yeah, they COPD, but they may not retain CO2. And COPD is a combination of 2 diseases. It's emphysema and bronchitis together. A pulmonologist has to make the call, and it's based on pulmonary function testing. We can't look at the patient and say they have COPD. We might see the manifestations, but the diagnosis is based on pulmonary function testing. And a pulmonologist will make that call. He or she will interpret the PFT, and based on the severity of decreased airflow on expiration, they'll make that call. And we could too, because you're going to learn PFTs. We could do it, but of course the physician has to diagnose. So just because a patient is COPD doesn't mean they're CO2 retainers, right? But all CO2 retainers are COPD. Got that? And so with COPD, it's classified stage 1, 2, 3, and 4. And just to keep it simple for you, generally stage 1 and 2 COPD patients are not CO2 retainers. But stage 3 and 4 are. The more severe the airflow, the greater risk of them retaining CO2. Make sense? And terminal means stage 4, and the curtain is closed.
So once there's CO2 retainers, that means that they're living off of peripheral, and they no longer have that
Central chemoreceptors. Right, that's another good way to look at it. Stage 1 and 2 still have their central chemoreceptors. And if they stop smoking, some damage is done, but they'll never be CO2 retainers. But most of the time, that's not the case.
Just give me some questions, but if you have it through, where you're saying our bronchitis is through, and we have a blockage, we're breathing in, why is it always harder coming out than going in?
Because expiration is passive.
Okay, that's what I
It's
wanted.
kind of like if
Okay.
you kick your leg up, you really don't have to think about bringing it back.
Right.
The effort was kicking it up, and then it just comes back. Expiration is
So
passive.
it's just because it's fast.
Because with our lungs, compliance is the ability to stretch. And elastic recoil, if it stretches, it'll automatically return to its natural shape. So expiration is passive. So if expiration is passive, it's got a resistance, and that's what we call airway resistance, because it's now got to go back through these excessive secretions or these bronchospasms, and that's difficult for an asthmatic and a CO2 retainer. That's where the problem is on expiration. Does that make sense?
Yeah, it makes sense. I just want to make sure I was
Yeah.
thinking it through correctly.
Because you got your diaphragm for inspiration. Expiration is just simply passive. Yeah.
Sometimes does it happen that asthmatic also becomes fluctuated by like at the right time they become CO2 retainers?
No. They always, we have our central chemoreceptor. No. They become static asthmaticus. They become worse, but they're not CO2 retainers. No, don't cross wires. COPD is emphysema and chronic bronchitis. It's not asthma. No. Okay? All right. Okay, any other questions? You kind of understand? That's all Poussin's law is about, airway resistance. You got a diameter, and if that lumen of the diameter closes, it's going to make more difficult for air to get through it. That's all Poussin's law is saying. Plain and simple. Got it?
Thank you.
Don't sweat about it. So, laminar flow is breathing easy. Laminar flow is good. Turbulent flow, your author uses turbulent, that simply means an increase in airway resistance. So when you have a patient that has when you have a patient that is increased work of breathing or a patient is short of breath, automatically think of an increase in airway resistance. And then what's causing it? Is it an obstructive disease where they're having a difficult time exhaling, or is it a restrictive disease where they're having a difficult time inhaling? Now that's we're in another ballpark, and you'll get there, but right now we're just working on obstructive disease. Make sense? And for some restrictive diseases, as well as COPD, the biggest culprit is cigarette smoking. It's not the only etiology, but that's preventable. And most people don't know. Most people, we don't realize how precious we are, period. Life is precious, but we don't realize how precious our lungs are, right? So when the high school kids were here the other day, I hit smoking blunt, and they looked, you said smoking blunt. Sure did. Hookah pipe. Potentially. Secondhand smoke is just as bad as smoking, yeah?
With somebody with COPD, like if a kid was growing up with their parents smoking, they hit 20 and now would they have COPD?
No, probably not COPD, but what happens is with the last time I read, which was last year, 350,000 children annually have chronic ear infections due to secondhand smoke. Okay, and some of them, particularly the girls, around puberty, when they start menstruating, will develop asthma, and we don't know why, and they'll have asthma the rest of their life. Whereas little boys can be born with asthma or develop asthma anywhere between 4 months to 2 years old, and because of testosterone, they can grow out of it, and we don't know why.
Is that anything to do with secondhand smoking?
Yeah. They've done studies on cats, felines, and they have found that cats who have owners, cats don't smoke, owners, right? They have tumors, they develop cancer, and they develop COPD because their owners smoke. Yeah. And another problem is diabetes, but that's a horse of another color. They do studies on animals, and most people don't know it. What you have to do, and I don't have it on our website, I don't have it, maybe I'll put it up. Go to American Lung Association. Anything you want to know about a lung, American Lung Association knows it or has done the research or in the process of doing it. I say abreast of ALA, American Lung Association. I'll put that website up on the, so you can go. Yeah, there's all kind of stuff. They have said anybody that lives in Michigan, if you're not born with a problem, you'll have one if you stay in Michigan, and I believe it. Allergies, hay fever, bronchitis, acute bronchitis, and it's true.
Especially
because we
southeastern
live in an
Michigan.
industrial environment.
They southeastern Michigan especially.
Yeah.
See, I've always been interested in that because I grew up in Florida. I was born here, but I grew up in Florida. In Florida, I had bronchitis and pneumonia nonstop during my youth. But up
Well,
here,
that was you.
I know, but up here it's always sinus. So I
Sinus is another one.
Yeah.
Yeah.
I think it's interesting how your body can react completely differently to different environments.
I'll put it up for you. Yes.
Well, if that's the case here in Michigan, I can only imagine what China's gonna be like in the next 20 to 30 years.
I don't know, I really don't keep abreast globally, but I do keep abreast, nationally. And then, this is just my preference, I like Channel 4 News, and I like Dr. George. And Dr. George talks about in Wayne County, this is what's high, in Macomb County, this is what's high, if you pay attention, And then that helps me, that's why my nose is running, whatever, particularly the mold. I'm just attuned to that kind of information because I have asthma, but the more I know about it, the better I can control it. Yeah, because I was a mess when I was a teenager. I stayed sick all the time, but I didn't know. And then we didn't know then what we know now. So we know a lot. Okay, any other questions? The airway going around, the bronchus going around? Everybody seen it? Any questions with it? So this is an excellent diagram as well as model what you have of Poussin's law. And so, thank you. You can see with the bronchoconstrictions and you can see with the excessive secretions. See how just this one here, this one alone, has decreased that lumen probably by 40%, just those excessive secretions sitting there. That's going to cause a problem to have a patient have a problem exhaling. Okay? Because see what happens on inspiration, it sounds gross, but because of gravity, secretions can move down. Make sense? But try to exhale. These secretions, because they're heavy in air, they're not going to move up. You see that? All right. So that's why they begin to struggle on expiration. Your COPD patients. And everybody, that may not be the primary problem, but if this happens, it's a problem. So what you want to do, even though we're not primarily responsible for it, we want to make sure that our patients are hydrated. Because when you have sufficient amount of water in your body, this will help liquefy secretions as well. Because if the airway is not adequately hydrated, then you develop mucus plugs. And mucus plugs can be difficult to move. And then there's other modalities that you'll learn next semester to help facilitate mucus plugs. And then look at this. If this airway, now this is an airway, if this airway fills enough with secretion, it will impede gas flow to the alveoli, and then the smaller alveoli, the microscopic alveoli, will begin to collapse. Because secretions have blocked airflow. Does that make sense? Secretions can be dangerous in the airway and to the lungs.
Does it hurt you? Is it uncomfortable when you suction patients, or does it feel good because of the
It depends on what's going on. It depends. Suctioning itself is an invasive procedure, so it may, everything good for you may not feel good to you. I'll just leave it at that.
Kids gotta love it, I'm sure.
I'll just leave it at that. I wouldn't want you to suction me, but if I needed to be suctioned, I would understand. It's just like going to the dentist. If you don't take care of your mouth, you don't want your tooth pulled, but if it hurts bad enough, you'll let them pull it. Okay, so that's Poussin's law. How about that? Okay, because I've heard, I just heard, and so I said, this is wonderful. Okay, so let's open your respiratory care pharmacology workbook. La, 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 la. And it begins on page 11. Okay, it would help if you know the key terms and definitions on 11, and the top of page 12, I want you to do that. Do number 11 and 12. And 15. Oh, number 16 is a good one on page 13. Turn to page 14 and do 25 through 35. I want you to do 36, 37, and 38. At 36 and 37, I haven't really discussed it, but it talks about a fast-acting, short-acting drug compared to a long-acting drug. Just for your reference, right here, our rescue drugs are short-acting. Got that? And our controller drugs are long-acting. This is really for an asthmatic and COPD patient. So rescue drugs are short-acting. Patients come in ER experiencing bronchospasm. We want to give them a rescue drug right there. They're called rescue drugs or reliever drugs. That's short-acting. All right? We send them home on long-acting drugs to maintain and control. Does that make sense?
Mm-hmm.
All right. Okay. Under pharmacokinetics of inhaled aerosol drugs, I want you to do number 39 through 48. And then starting at the bottom of page 18, do number 1, number 2, on page 19, number 4, number 5, interesting. Do number 7. I haven't gone over, but let's see if you can get the right answer for number 7. Number 8. Number, on page 20, everybody with me? Number 10, 11, 12, 14, 15, 16, 20, page 21, 17, that you should know by now. Number 18 you should know by now. You've been quizzed on that. Number 19, number 21, 22, 23, 24, And that's it for chapter 2. Now let's go to chapter 5. And I want to come back to page 22, okay? I want to come back, but we'll go to chapter 5 now. You guys should have been working on this. Chapter 5 starts on page something.
57.
Thank you. 57. Do all of 57. Do all of 58. Do all of 59. You should know this by now. All of 60. Ooh, and I love 39. Do all of 61. This is all about alpha, beta 1, and beta 2. Now for number 39D, 39D, dopamine. 39D, it's an adrenergic drug, so what am I saying? What's this nervous system? SNS. It's a beta 1 drug, so it's a cardio accelerator, right?
Yes.
But it's positive inotropic. Dopamine. Positive inotropic. So what am I saying when I say positive inotropic? There you go, dopamine. That's number 39D. You should know that by now. Increase in myocontractility force, meaning it increases cardiac output. Right? All right. Okay, let me see. Do all of 62. Yeah, you should do the whole chapter for chapter 5. Whole chapter, chapter 5. The only thing that I have not discussed, and I can very quickly, and some of you don't get your panties in a while. Muscarinic. Muscarinic. See muscle? It's that part muscle. This is how I relate. What's the function of the parasympathetic nervous system? It's homeostasis, right? And what the parasympathetic nervous system does is sends messengers to the muscles or wherever it's going via acetylcholine, right?
Right.
Well, they call also, it can be referred to as parasympathomimetic, yes? It can be referred to as cholinergic, but sometimes it's also, this system is also referred to as muscarinic because the acetylcholine is sending messages to the muscles to function. So whether you see parasympathomimetic, whether you see cholinergic or muscarinic, they mean the same thing. Myasthenia gravis, I want to come back to this. Wow. I never knew this was in here. That's because we never looked. Okay, so muscarinic is the same thing as a parasympathomimetic or cholinergic, all right? Because I did happen to notice it in the book, and I think somebody asked me about that. Does anybody remember who asked me about muscarinic? Does anybody recall asking me about muscarinic? And I said, I haven't explained that yet. Okay, but here it is now. So when we see a drug that's muscarinic, we know that it is a parasympathomimetic, and a synonymous term is cholinergic. Where do we get the cholinergic from? Because of acetylcholine, ACH, right? Okay. So these three things mean the same thing, muscarinic.
We talked about in the article about muscarinic.
I'm sorry?
We talked in the article that we did about that.
Muscarinic. Okay, very good. So what is anti-muscarinic?
Cholinergic.
Right. So can antimuscarinic be synergistic to our beta agonist? Yeah, they are. So we can say anticholinergic or we can say antimuscarinic. They decrease 3,5, I see your hand. They decrease, if we say antimuscarinic or anticholinergic, same thing. I didn't spell that correctly.
Close.
Okay, decreases GMP, and a very good drug is Spiriva. We give this to COPD patients, Spiriva. It's tropium bromide.
So you say,
Yeah, there's parasympatholytic, that's another name.
okay.
Yes, I can put that up here.
Now, would that be considered I would think that would be considered a PNS, but because it decreases GMP, that would be could we call it SNS?
No.
So it is PNS.
But yeah, it's it's still PNS. It blocks the release of acetylcholine. Acetylcholine doesn't have anything to do with SNS.
Right. There was one that we had that really threw me. I think it threw a couple of other people too. That we thought that it was it depressed the GMP, and we thought that if it did that, then of course it would be a PNS. But we found out that it was really an SNS. Does anybody else know what I'm talking about? Have a problem with
Be specific. Tell me what you're talking about.
Right. But any time it depresses, I know if I see cholinergic in there, I know what it is for sure, or parasympathomimetic. Yeah, I think it was catecholamine that threw us. Catecholamine is an SNS. Miss Miller, I can't think of it right now. I won't.
Well, catecholamine doesn't have anything to do with it.
No.
Catecholamines are naturally occurring hormones in the body. That's your epinephrine, norepinephrine, insulin, all those are hormones.
If I think of it, I'll send you an email.
Yeah, that's what I say. You have questions, you got to be specific, because I don't want to give you wrong answers.
Right.
That was my bad too, that's what
All right. So muscarinic is the same thing as these. So parasympatholytic, antimuscarinic, or anticholinergic decreases 3,5-GMP, and these are our backdoor bronchodilators. Backdoor bronchodilators. They don't have a direct effect on 3,5-AMP. Backdoor. You know how you slip in some?
Nice.
Oh, I thought you had your hand up. Okay. Merriment is good for my soul. Every day I must laugh, so I laugh at Kathy. I don't laugh at people, I laugh at me. But then again, I have a sister that is a clown. Anyway. All right, we got it? All right, so back to what I was doing. I was on a tangent there, wasn't I? No, on page 64, I saw muscarinic, so I wanted to clarify. Okay, that's chapter 5. Now let's very briefly go back to page 22. We're moving along. Page 22, case study. Case study 1. Everybody with me in the workbook? It says, R.E. is a 24-year-old man who's been brought to the emergency room by his wife because he has a high fever with shaking chills for the past 24 hours. R.E. states that he has had bronchitis for the past couple of weeks. He says that he is short of breath. His respiratory rate is 32 breaths per minute. So what do we call that 32 breaths per minute? What's another name?
Tachypnea.
Right. And we probably can assume he's got some increased work of breathing, right? All right. For the past couple of weeks. His heart rate is 108. Okay, why do you think his heart rate is elevated? The increased work of breathing. We don't have a pulse ox. We don't have a PO2. But remember, the first compensatory response to a low PO2 is tachycardia. So this man doesn't have a heart problem. Anytime a person is short of breath or anytime a person is hypoxemia, the first thing that's going to manifest is an increase in heart rate. Okay, so his isn't bad, 60 to 100, and men's generally heart rate beats a little faster. So 108, okay, it's on its way up. And his respiratory rate is 32. So here we are. His heart rate is 108. Auscultation, meaning that the therapist or doctor, whomever, took a stethoscope and it revealed bilateral crackles in the lower lobes. Crackles is secretions in the alveoli. When secretions are in the alveoli, we call them crackles. That's a brush sound you'll learn next semester. And then when secretions are in the airway, we call it bronchi. I'm writing it on the board. Hold your horse. It's called bronchi. Secretions in the alveoli are called crackles, and secretions in the airway are called bronchi. Now, secretions in the alveoli will not clear with cough, because they're in the alveoli, and they're not coming up with a cough. Got that? Bronchi may clear with cough if we give them a well, in this case, give them a bronchodilator or whatever they may need. So bronchi can clear with cough. Now let's do this again. Crackles are secretions in the alveoli. When do we hear them? On inspiration. That's how specific we as therapists get. Crackles are secretions in the alveoli, and we hear them on inspiration. They do not clear with cough because they're down in the alveoli. Got it? Any questions? Bronchi are secretions in the airway, the conducting airways. We hear them on expiration. And sometimes they're cleared with cough. Meaning you may not get them all, but you should hear some improvement. Does that make sense? So you learned two breath sounds. Crackles. Where do we hear crackles? In the alveoli, meaning the periphery. And they do not clear with cough. They can't because they're stuck in the alveoli. Remember I was saying secretions are heavier than air? And they're not coming up out of the alveoli. We got to do something. All right, so bilateral means both sides. So this man's got double trouble here. He's got secretions in his alveoli, and whomever listened heard the secretions on inspiration. And then it said he's got bronchi, which was heard on expiration. So it probably initially started with secretions in his airway, and it gravitated and moved down to his alveoli. Because he's had bronchitis for 3 weeks. Does that make sense? Okay, so that's what that's saying. And bilateral means both sides. All right. So he has auscultation, breath sounds, reveals bilateral crackles in the lower lobes. Lower lobes, that's why you had to learn right middle lobe, right lower lobe, right. You had to learn the lobe. So his alveoli are full of secretions. And he's got bilateral wheezing heard on inspiration. Now, initially, when did it start?
Past couple of weeks, 2 weeks ago.
It started a past couple of weeks ago. Now remember, he's got bronchitis, and I told you it doesn't say he has asthma, he has bronchitis. But generally when wheezing starts, it starts on expiration. The patient has a difficult time exhaling. But he's had bronchitis for 3 weeks, and these secretions, this fluid has been draining. and it's drained and gotten all the way down in his alveoli. So we hear the crackles, and now he's wheezing on inspiration. So just with that information alone, you know he has an increase in worker breathing, and he has an increase in airway resistance. Does everybody understand what I'm saying? This is how we think. If a person has wheezing on inspiration, they're in trouble with wheezing on expiration. But it's gotten worse, because at least on inspiration you have your diaphragm, right?
Right.
But if you're wheezing and using your diaphragm, you definitely are using accessory muscles. So he's in trouble. He's in trouble because he's got secretions plugged down in his airway, and he's got secretions plugged down in his alveoli. We don't have a blood gas because the focus in this book is pharmacology. But do you think he might have a little shunting going on?
Oh, yeah.
You bet your sweet buddy, because whatever's going on, those secretions are interfering with gas exchange. Make sense?
Yep.
All right. All right. So it says he has bilateral wheezing heard on inspiration. Not good at all. After examining him, both you and the physician agree that RE probably has pneumonia. Well, this is pharmacology, but if they agree, they get a chest x-ray. The only thing that confirms pneumonia is a chest x-ray, but it's pharmacology, so I'll go along with it. Okay. So, RE will need a bronchodilator for the wheezing and antibiotics for the pneumonia. Would you agree?
Yes.
Okay. It says, what route of administration would be best to deliver the bronchodilator and antibiotics? So how are we going to deliver the bronchodilator? Inhalation.
Aerosol.
Small volume nebulizer. Yes.
With them deciding that it's like bilateral, would they give him a boost of antibiotics at the ER and then send him home on a prescription?
No, they're not going to send him home.
No.
Or if they send him home, not right now.
But it's
He's
because
got to
it's
be
bilateral.
cleared.
If it's like, sometimes we'll send you home if they don't think it's severe pneumonia.
Then he needs a chest x-ray.
Okay.
That's all I'm going to tell you.
Okay.
He needs a chest x-ray, and that would determine the severity of the pneumonia.
And that would depend on.
Yeah. They didn't put all this in here
I
because the
know.
focus is the drug.
I know.
Yeah, but he got to have a chest x-ray. If you give me a chest x-ray, then I can tell you specifically if they'll keep him or not. Okay. What drug will be best for his symptoms of bilateral wheezing on inspiration? What drug do you think would be good? Does he need a reliever or does he need a controller?
A reliever.
He needs a reliever. So he needs, we haven't gone through the drugs specifically, but he needs a short-acting beta-2 drug. Albuterol, good.
Yeah, beta, yeah.
Short-acting beta-2 drug. We're not going to send him home with a controller. Did it say he had asthma?
No.
He's wheezing because he's got pneumonia. Does he have mast cell degranulation? No. What's another reason for wheezing? Excessive secretions. How do we know he has excessive secretions? We heard crackles on inspiration, which is fluid in the alveoli. They heard bronchi on expiration, which is fluid in the large airways. Make sense?
Yeah.
Okay, so here's a man wheezing that does not have asthma, so there's no mast cell degranulation. His cause of wheezing is from excessive secretions because he's had bronchitis for the past 3 weeks and apparently must not have been taking any medication to treat it. He probably should have been on the antibiotics 3 weeks ago. Because it makes me wonder, well, how do you know you have bronchitis? And now you're coming in 3 weeks later. He probably should have had it. Okay, and inflammation and bronchitis, what is this? Itis. Inflammation. He's got inflammation of the bronchi. His bronchi are swollen. So he's got excessive secretions, and he's got a swollen airway. That's what caused him to wheeze. So this is not asthma, and this is not mast cell degranulation. So when he does go home, he doesn't need a controlling drug. He needs relief right now, and we need to make sure that he's relieved before we send him home. Because once the bronchitis clears up, he will not need a beta-2 agonist drug anymore. Could be. We got to see how the antibiotics do. Sometimes the antibiotics will be so effective it will eliminate or alleviate the swelling as well. We have to see. Does that make sense?
Yeah.
Okay. And truly, if he had pneumonia, they'd have to do a chest x-ray to confirm it. You can't listen to a patient's breath sounds and say, oh, you've got pneumonia. Don't do that. All right. So he's been admitted to the hospital, so it was bad enough. He's been receiving albuterol treatments via SVN, and he's feeling much better. His respiratory rate is 18, and his heart rate is 84. Why did his rate go down, and his respiratory rate go down, and why did his heart rate go down?
Yeah, decreased work of breathing.
We decreased the work of breathing because we dealt with the increase in airway resistance, didn't we? Good. Very good. Okay, the bilateral wheezing has been reduced. It didn't say that it's gone, but he now has a slight wheeze bilaterally, so he's got a little wheeze, but it's not as bad. RE comments that a lot of medicine seem to be going in and out of the air, and he can taste it in the back of his throat. How much of this stuff really makes it into his lungs? What would you tell him? See, and patients will ask you stuff like this, and you've got to be able to address it. What would you tell him?
23%
Of what?
of the drug inhalation statements that are making it into his lungs, the rest is going to go to his stomach.
Where you get those numbers from?
Both.
Very good. Go ahead, repeat. Listen to Amy.
Could he just use the fact that they're feeling better as evidence of the medicine is doing what it's supposed to do now?
Absolutely. Your respiratory rate has decreased. I don't know if you're aware, but when you came in, your heart rate was elevated. Now your respiratory rate is normal. Your heart rate, and aren't you breathing easier? And although you may taste it, remember I always tell you, sometimes everything good for you is not good to you. And so he doesn't like taking this. A lot of people don't come in until they really get sick because they don't want to take medication. They have a fear of medicine. They have misconceptions about health care, or maybe they remember when they were little and they went to the hospital to see grandma and grandpa, and grandma and grandpa died, and they have, you'd be surprised why people won't go to the doctor or come to the hospital, and then cough is a big factor. But nevertheless, sometimes they come. So you'll have people, you'll have patients like him, and you'll have to talk to him and tell him. And I would use Amy's approach. I would approach it, don't you feel better? When you came in, I noticed this, and your heart rate was this, but now your heart rate is normal and your respiratory, and aren't you breathing easier? So this medication is working. If you keep taking it while you're in the hospital, and you've only been in the hospital for 2 days, you won't be on it much longer. That's how you approach it, because you're going to have them. My doctor ordered Zopanet. What is that? And how do I use it? And you need to be able to tell them. But they're going to ask you all kinds of questions. Okay, the doctor has ordered albuterol MDI to be used at home. Why? You suggest that RE should also use a spacer. I haven't talked about spacers. The doctor does, okay, well, we can't answer that because I haven't talked about spacers. All right. All right, so we're going to have, do more case studies as such. So you got your assignment, and you know that is due when? When is this workbook assignment due?
Thursday.
No, it's due Thursday the 31st. Yeah, when I sent that email out, I realized, I said, Kathy, you made a mistake. Yeah. This is due Thursday.
Oh, okay.
Workbook 1, 2, and 5 is due Thursday. Yeah, in my email I said the 30th, but that was an error. I should have typed the 31st. All right? I said workbook 1, 2, and 5. The only test you're going to have in here is the final.
Okay.
And it's cumulative. All right, let's move on. What I want to talk about, and I didn't bring my book, I want to move to Chapter 3, talk about MDIs and DPIs and small volume nebulizer. I know you've probably seen it in lab, but I can't assume. I gotta find one. Help me, I not know. I might be one over here. I had one over here Friday. Oh, no, that one now, yes, please. Okay, this is a large volume nebulizer. This is my teacher stethoscope. I gave the skeleton the name Gus. The high school, I love I wouldn't want to teach him, but I can talk to him. I wouldn't want to be with him all day. Okay, all right, this is a large volume nebulizer, and I know you should know the difference, but I'm not going to assume. Yesterday, we talked about low gas flow systems. This is a bubble humidifier. This is low humidity. It's molecular water. This is a large volume nebulizer, and I know it delivers high humidity. Number one, I see the difference. This is a small bore opening. This is a large bore opening. So low gas flow systems are connected to here. High gas flow systems are connected to here. Tomorrow I'll be going through Bernoulli's principle and Venturi's effect. All high gas flow systems have that principle, another law, Venturi's effect and Bernoulli's principle. All right, so nebulizers. Both of these are nebulizers, and all nebulizers produce high humidity. The purpose of this nebulizer, it's a large volume nebulizer. It is to deliver high humidity. And we deliver high humidity to an airway where the nose has been bypassed because it can't humidify. Does that make sense?
Yes.
Okay, so this could, in some instances, I don't want to say do, but serve the purpose as the nose does. And if we wanted to, we could wrap heat around it. Not on this plastic, but it would have to be a different type of nebulizer. So we could even warm this water to not only humidify, but to heat it as well, if we wanted to. So this is a large volume nebulizer. This, too, is a nebulizer, but this is a small volume nebulizer. It can be used, this is an aerosol mask, and if we took large bore tubing, I'm just going to take a short piece. I'm not going to take a long piece. Better yet, I'll use this. This is large bore tubing. All large bore tubing is not blue. It just happened the company that we got it from is blue. It can be clear, it can be yellow, it can be white. This is large bore corrugated tubing. Large bore corrugated tubing is always connected to a large volume nebulizer. All right? Large volume nebulizer is a high gas flow system. This is low. Low humidity and low gas flow systems, FiO2 variable, right? Yes. All right. This is high gas flow system based on Bernoulli and Venturi, which we'll go through tomorrow. I see the large bore opening and corrugated tubing connected to it. Yes? All right. This mask is by itself is nothing. It's just a mask. It's an aerosol mask. But connecting it to this is a delivery device. The tubing obviously would be longer. I'm just making a point to show you how stuff connects, right? All right. Isn't that wonderful? All right. So we can use, this is still a nebulizer. We could use it here, or we could take this off and use a mouthpiece. It's still a nebulizer. What makes both of these nebulizers? They're both nebulizers because they produce aerosols. They produce aerosolized particles. Aerosolized particles. We generally use sterile water for this, never ever tap water. We use sterile water for this, and this is continuous. When we use this, this is continuous. A patient could be on this for 24 hours, 36 hours, whatever. In addition to the high humidity, if we wanted, I call it high humidity or aerosol. Those words are interchangeable, high humidity or aerosol. In addition, if we needed to, we could deliver oxygen. So if I connected this to compressed air, the patient wouldn't receive an FiO2. They would still be breathing room air. Does that make sense? Mm-hmm. But they would get high humidity aerosol, and we can do that because they need the moisture in their airway for whatever reason. Make sense? Or I can take the same nebulizer. Don't let this color distract you. I can still take the same nebulizer and connect either to an H tank or this and connect it to oxygen. It's going to do two things. Deliver a specific FiO2 that's not variable, meaning if I put this on 40%, that's what the patient's going to get. If I put this on 35%, that's what the patient's going to get. Whereas in a low gas flow system, the FiO2 depends upon what? The patient's what? Be specific.
Minute ventilation.
Okay? Still oxygen, but I can deliver a specific FiO2 with this. This is a nebulizer. The purpose of this nebulizer is not to deliver FiO2. The purpose of this nebulizer is to deliver our pharmacological agents, our beta-2 agonists, our anticholinergic, our antimuscarinic, our anti-inflammatory, or whatever. So this is one mode. This is not the only mode. So both of these are nebulizers. How do I know they're nebulizers? Because they both produce aerosol. The purpose of this one is to deliver high humidity. The purpose of this one is to deliver medication. But they're both nebulizers. This is called LVN, what I call it, and this is called SVN, small volume nebulizers. And how do I know they're nebulizers? All nebulizers have in them what's called a baffle, B-A-F-F-L-E. You'll probably see it in equipment in labs. Has Ms. Polk gotten to that yet? Yes. Okay. Baffles. All nebulizers have baffles. And so what's the purpose of the baffle? Create the aerosol particles. And when they create the aerosol particles, specifically, what about it? Specifically, it creates the aerosol particles, but now let's get more specific. Uniform aerosol particles. And why are we concerned about uniform aerosolized particles?
Because they're bigger, they won't absorb as well as smaller.
Better deposition, better penetration into the smaller airway, right? Meaning the smaller the particles, the further it will travel. Mm-hmm. We're not trying to get the particles to necessarily travel to the alveoli. That's not where bronchoconstrictions occur. Bronchoconstrictions occur between the first and the 19th generation. And I told you before, in most adults, it's the upper airway or the bronchi, and in children, it's the bronchioles. So with the baffle, whether on this or this, the aerosolized particles are penetrated and deposited further into the airway. So this is a small volume nebulizer. So again, this one will go in and administer treatment. It may be 10 minutes and we're done. Large volume nebulizer, the patient remains on it and can receive a specific FiO2 as oxygen therapy. Okay, so both of these are nebulizers. You as a therapist know appropriate use. When to use this, when to use this. Okay, this is a high gas flow system. All high gas flow systems deliver a specific FiO2, whereas a low gas flow system, the FiO2 is variable based on the patient's minute ventilation. Any questions on anything I said? I'm crossing wires here. I'm crossing 201 with this class, with why not? We're all going the same way. Any questions? So whether you see this or this, identify nebulizer. What's it used for? To deliver high humidity and a specific FiO2. What's this used for? To deliver medication. How do you know they're nebulizers? Because they both have baffles. I'm going to pass this little top around. Right here is the baffle. So I'm going to show Middleton, and Middleton is going to show Sherry, and Sherry's going to move on, and everybody will see the baffle right there. Yeah. Absolutely. See it? I don't have anything small enough to point to. Let me see if I can find the baffle.
Baffle.
Baffle in the middle.
I can't see the baffle in this. I probably have to take it a little.
So it's rounded and it's kind of
I don't see the
versus
baffle in it.
probably
Right.
there.
Have you ever used one or no?
Huh?
A nebulizer like that or no? No. I didn't know if your kids or anything.
Nope, can't see it. Pass it around so everybody can see the baffle. Why is Kathy Miller showing you the baffle? You know she's going to ask you what a baffle does, right? A nebulizer cannot function without a baffle. If a nebulizer does not have a baffle, then it's called an atomizer. Like the perfume. So the difference between an atomizer and a nebulizer, atomizer doesn't have a baffle. So it can't produce uniform particles. Make sense? A nebulizer does. So all nebulizers have baffles, whether it be large or small. Any questions with that? Okay. So I'll ask you, what's the purpose of a baffle? And the answer will be to produce uniform particle sizes. Why do we want uniform particle sizes? For better penetration and deposition into the lower airway. Does that make sense? Okay. So one way we deliver our medication is via small volume nebulizer. That's one way. Our aerosolized medication. So the doctor can write FDN with albuterol. He or she may not. They just might write that. Does that mean you can't get a treatment? You know how to administer. Yes.
One thing I thought that was high flow nasal cannula. Is that bland therapy or is that
High flow nasal cannula? You don't deliver medication with it?
I didn't guess that, but I just...
No. That's oxygen therapy. That's just oxygen therapy.
So only through high flow systems will we be,
Ooh, I spelled that wrong.
only high flow systems you'd be administering drugs. Is that correct?
No, you could do
No,
both.
that's only one
Low flow. What, you got to be more specific. I don't know. I hear you, but I don't know what you're asking.
So on a low flow system, typically you wouldn't be administering drugs through that small volume nebulizer.
A small volume nebulizer is a high gas flow system.
Yeah, so my question was, we wouldn't be, a low flow system typically will not include drugs. Is that right?
Low flow systems are to deliver oxygen.
That's only for oxygen therapy?
Yes.
Okay.
Yes.
I was just a little confused.
Oh, it's okay.
I'm good now, though.
Oh, good, all right. All right, so you can administer your albuterol via small volume nebulizer, or it can be MDI, that's meter dose inhaler, or it could be PDI. Now, albuterol don't come PDI. I got it backwards, I'm saying PDI, it's dry powder.
DPI.
I'm not dyslexic.
I know, I was
Dry
like,
powder
what's
inhaler.
that?
These are the three ways, okay? Now, if your patient's in the hospital and you're going to the patient's room, more than likely it'll be small volume nebulizer. MDI and DPI is what the patient will use at home. But these are the three ways. You're responsible for small volume nebulization, and then Laura just mentioned your son, daughter? Son is at home on this, so sometimes patients do go home on it, but they don't have this. They have a small machine. I'm not going to equipment, but Ms. Pope and Ms. Pearson and Erica will go through those to show you, and you may have to show a patient how to use a small volume nebulizer at home. Do they need to know about a baffle? No, they don't need to know that, but you do. Okay? So the difference between a large volume nebulizer and a small volume is this can deliver an FiO2, and it's specific, and it delivers aerosol high humidity. It's for humidification purposes. This is to deliver aerosolized meds. Okay? You got that? So we know what appropriate equipment to use. And in selecting equipment, part of our responsibility is to know whether it's working effectively or not. Everybody saw the baffle? Any questions? So you know the purpose of a baffle. A bubble humidifier doesn't have a baffle because a bubble humidifier doesn't produce an aerosol. It produces molecular water. Okay. Now, as far as infection, I'm just getting a little ahead of myself. Minimal danger of cross-contamination. Minimal, because this is molecular water. The water particles produced in here, it's too small for pathogens or microorganisms to ride on. This, however, big difference, because these are aerosolized particles. Colonies of bacteria, whatever, viruses or whatever, can get on these particles and ride, and they'll ride the wave right into the airway. So it produces high humidity, but it's also a source for contamination in the airway. So we have to be careful using these, yes.
With the bubble humidifier, there is a non-reusable option.
Most of them are non-reusable.
Is there a non-reusable option with the large volume nebulizer?
This just so happens to be the ones we have in here. Yeah, but yeah. And actually, they are non-reusable. It gets to a certain level, throw it out, get another one, and it minimizes. There's no risk of contamination.
That was where my question came from.
We've gotten better. Now, these didn't exist when I was in school. This stuff didn't exist, but it does now for that reason. Because they try to blame a lot of nosocomial infections on respiratory care equipment. And this is a culprit. This fella here is a culprit. It really is. Especially for a compromised airway, someone with a trach. We get them, but they need it. So we have to be careful. Okay?
That stuff out and maintains it.
We don't wash it out, throw it out. It's disposable. Throw it out. Get rid of it. Yeah. Get rid of it. And this is actually why we have a lot of it in equipment in here, because it was donated, or some of you perhaps got it in your kit. But this is refillable. This one is refillable.
With the saline water.
We probably won't be
This is
seeing
not.
that.
Throw it out. When it gets to the, see the water level here, throw it out, get another one. Minimum contamination. This is disposable. Whereas this one, I should refill it. Even though it's a humidifier, because it's a humidifier, contamination is minimal, but nevertheless, if I have to take this top off and if I have to put water in it, whether I have on gloves or not, and I would, there's still a risk of contamination. So a lot of these are probably not even used anymore. This is used. It says on here bubble humidifier. It says on here it's for inhalation. It says on here that it's sterile water. And I see this small bore opening, so I know it goes to small bore tubing, and I know that is low gas flow system. And once this is low, throw it out and get another one and replace it. Right? All right. Because it minimizes contamination.
And we don't have an example of a high flow, large volume nebulizer that would be disposable here, do we?
I don't know. We may.
Yeah, they couldn't find one yesterday.
They couldn't find one? Okay.
But she said she did tell us in the lab yesterday that they're different, they're marked different. It'll say large volume. I mean, it actually said,
Yeah,
like,
it'll
it said
say
small and it says large on it. It may be different colors, so it just depends on the manufacturer.
Yeah, it depends on the
And one will be
manufacturer.
in one place and the
So
other
don't
one
get
in
caught
the
up in color, because this doesn't mean it only connects to compressed gas. That's not what that means. That's just how this manufacturer made it, a nice bright yellow. Okay? All right, so back to this. We can administer our drugs via small volume nebulizer. The patient can take a metered dose inhaler, or the patient may have a DPI. These are the three forms that we deliver our medication. And patients can go home on a small volume nebulizer, so they have to be educated either by us if you're in the hospital or a home care therapist, same thing, us, how to do this. And the MDIs and DPIs, they go pick up the prescription or they may get it in the hospital. They still have to be instructed how to use it. Okay? So your PowerPoint 3 is on Chapter 3. And I don't want to spend a lot of time on it. Water or medication hits against the surface, it disperses and produces uniform particle sizes, so it can be better penetration and deposition into the smaller airway, particularly that 10th through the 19th generation. Make sense? Okay. So much for that. All right. And if you look on page 33, it talks about measurement of particle size distribution, It's just saying what I just said. All right. On page 37, here are your nebulizers. It says the term nebulizer encompasses various devices that operate on different physical principles to generate a drug solution. The small volume nebulizer, the SVN, that's where I got it from, is generally pneumatically powered by a 50 psi source of oxygen. Do we need a 50 psi source of oxygen? No. It can be a 50 psi source of compressed air. Don't have to be. And who would we particularly have, what kind of patient have you learned may benefit from a 50 psi source of compressed air?
Somebody mentioned their nose isn't working properly, they hear it by ear. They don't really need the oxygen therapy, they just need the humidity and the warming.
That's true, but I wasn't going there. If I was going there, she got me. I'm looking for a specific kind. She is correct, but that's not the answer that I was looking for. CO2 retainer may not need the oxygen, but they need the medication. So that we could connect a small volume nebulizer to compressed air and deliver the medication. Isn't that wonderful? We can do that. Because when we have the small volume nebulizer connected to a 50 psi source, the focus is not delivering an FiO2. The focus is delivering the aerosolized drug, right?
Right.
And if that source of gas is there, it may raise their PO2. Now, maybe every 4 hours, 6 hours is not bad, but let's say we get someone with an acute exacerbation of COPD and we know they're CO2 retainers. We can't go in there and give them treatments every 2 hours using oxygen, because we're going to knock out their hypoxia drive probably within the first 2 treatments. So in that case, we would take our flow meter, connect it to compressed air. We'd have to have a compressed air flow meter, and your department will have them. And we can take that small volume nebulizer and connect it and still deliver that aerosolized drug with a 50 psi source, but no increased FiO2. Does that make sense? And so you have to know when and when not to use the oxygen or the 50 psi source of oxygen for the asthmatic, fine. But you might want to be careful if you got a CO2 retainer. Now, if they need a treatment every 4 to 6 hours, okay, no big deal. But if you have to give them, like I said, they're really bad, and you have to give them Q 1 hour treatments, Q 2 hours, I'd probably think about that. Because you don't know what kind of FiO2 you're delivering. And that's not the purpose of you using the oxygen. It's a gas source to nebulize, aerosolize the medication. Everybody understand what I'm saying? So you got to make a decision sometime, and you don't need a physician to tell you that. This is part of your responsibility.
Why wouldn't they just then use the compressed air? Why would they even choose to stick it on the oxygen?
Most of the time, like an asthmatic patient or other patients may need the oxygen source as well. They may be on a nasal cannula. Or it could be someone that's on a non-rebreathing mask, and you got to take the mask off to give the treatment. So while you're giving the nebulized treatment, give it through a 50 psi source of oxygen, so at least they're getting something during the treatment. Does that make sense?
It does, but if we should know then, probably in the chart anyway, it would say that they're a CO2 retainer. So
initially we may not know, but
okay.
Somewhere down the road we would know. And then during the patient, every time I give my patient a treatment, they look like they're going out on me. What's going on? You know, and then you'll have clinical manifestation.
Okay.
And so believe it or not, I want to say 25% of what you're learning is what you need to know, head knowledge. 25% is clinical priorities. 50% is going to be common sense of what you do. You got to learn how to prioritize. And when you start clinical, you ask clinical instructors, and you're going to be in clinical for 2 years or whatever. But 50% is going to be this common sense. And no physician needs to write an order to tell you about a CO2 retainer. Not one. That's why Kathy Miller keeps going over and over and over and over. And as second-year students, yeah, we got it. I don't even mention this stuff to second-year students because they know it. They understand it, and they were right where you were last year this time. All right. Okay. So let's look at box 3-2 on page 37, advantages and disadvantages. It says ability to aerosolize many solutions, ability to aerosolize drug mixtures, meaning that we can give synergistic drugs. We can give an anticholinergic drug, Atrovent, and a beta-2 agonist together. We can do that. Minimal cooperation or coordination required for inhalation. And guess what? If the patient can't do that, we can take the mouthpiece off and give them a mask. The treatment may not be as effective as if they could take in a deep breath. Or it could be a baby, and the baby is petrified of you. Mom can still hold the baby. And I would need a connector for it. I would need my T-bar. I don't know where it is, so I'm not even going to look for it. But I could blow this right into the baby's face. So the baby can still get something. When there is a will, there is a way. And you have to learn how to do certain things, depending upon the circumstance. Yes.
My daughter had a group. They did some sort of breathing treatment on her in their room where they just held the steam in front of her face.
Absolutely.
Was that what that was?
Aerosol.
Yeah, she was like kept turning her face.
Absolutely. Nevertheless, it may not have been as effective if she had cooperated, but she got some of it.
Yeah, she kept turning her head. I had to keep like.
Absolutely. That's exactly what I'm talking about. It can be done. It can be done. So, minimal cooperation is an advantage. Effective with low inspiratory flows or volumes, Normal breathing pattern can be used in inspiratory pause. So one thing about when you administer, whether it be DPI, MDI, or small volume nebulizer, what you want to learn how to do is you're going to instruct your patient, and you always instruct your patient before you begin the therapy. You don't begin the therapy, then start explaining it to them, because this medication is being nebulized. So you want to do all this before. You want them to tell them to begin slowly, this normal breath, but then when they inhale the medication, see if they can hold their breath. It would be ideal, book will tell you ideal 10 seconds. Everybody can't do that, particularly CO2 retainers. So for a CO2 retainer, you might be doing good. You'll be batting the ball out of the park if you can get them to do 3 seconds. And that's not long. But nevertheless, you want them to tell them, taking a deep breath and hold it. And while they're holding it, you're getting more effective penetration and deposition. So when you deliver aerosolized medication, the key is breath hold. Inhale, hold. Then exhale. And ideally, Egan's will tell you 10 seconds. That's ideal. Everybody can't do that. Let a person have increase in airway resistance, and 10 seconds is not going to happen. So don't get upset. The book says 10 seconds and the patient's only doing 2. That's all the patient can do. Okay?
Just don't do it as long as you can.
As long as you can. And then sometimes you go back. Because remember, they're going to love Mendelssohn, and the little lady is going to have that tissue full of secretions for him when he comes back. Sometimes when you go back, they'll say, you know, I don't like doing this, because after I did this, I had a headache. Then you're going to have to explain to them, that's from where they're holding their breath. You know what they're doing? They're hyperventilating. And when you hyperventilate, sometimes that will give you a headache. So then you got to sleep talk them. And Mendelssohn is going to smile and tell them, that's just temporarily while you're doing the treatment, but did your headache go away? And she said, yeah, I do feel better since you're here. You have some time. I had my first class here. They were the super sick. And I had a young man, the one that got mad at me because the patient wasn't wheezing and the book said this, that, and well, anyway. He called me a couple of years ago and he said, Miss Miller, I had to call you. And I said, you know, we talked or whatever. He said, I had my first patient hit on me and I hollered. It was an older lady, and she wanted to take him home. And I could just see him blushing on the phone. I said, you made her feel real good. And he said, he said, I used to think when you were talking, you were crazy. I said, I know. I said, most students think I am crazy. I said, maybe a little bit crazy, but I know respiratory care. He said, well, I finally got it. He said, the lady was rich. I said, you didn't go home. He said, no. He said, I didn't want to leave my wife and 2 boys. I said, well, I guess you made the right decision. She got excited. I said, she liked what she saw, didn't she? So anyway, you have to, he tickled me when he called me. I hollered. So, yeah, it is. It's funny. You're going to have some experiences, but you have to ignore it. When I say ignore it, you have to handle it right. You know, you have to be professional. You have to be professional. You might have a flasher. Not the first time. All right. So, normal breathing patterns can be used in inspiratory pause. It says breath hold, not required for efficacy. It may not be required for efficacy, but if you can, meaning like for her little girl, your little boy, her little girl. Okay. The babies, the children, the small children aren't able to hold their breath, but if the patient is, as an adult, if they can hold their breath, you're going to get better penetration and better deposition. Okay, so for patients that can't follow your instructions, see if you can get them to a breath hold. Or maybe you tell them you don't have to do it every breath, but try to do a breath hold. That's an advantage. Drug concentrations and dose can be modified. Now, look at the disadvantages. Equipment required for use is expensive and can be cumbersome. Treatment times are somewhat lengthy, ranging from 5 to 20 minutes, depending on the amount of drug and the type used. There is variability in performance characteristics among different types of brands and models. Well, with that, you don't have a control what your department buys, but there is someone in your department that is responsible for quality control, and it may not be the manager. You're always going to find somebody, and maybe one day you might be in that position for quality control. You're monitoring the efficacy, you're monitoring the cost, it's always cost. You're monitoring certain things about what people are using in your department. You have no control over the quick connect that's used in your department. Whatever your department buys, that's what you use. But that could be an issue, and it may be a decision where your where your department changes from one company to another company. Don't get freaked out about equipment, because when your department buys new equipment, there's always going to be a rep that comes in and instructs your department on that equipment. Always. And you may have to come in on a day off, or you may have to come in 2 hours early to get the instructions. And most therapists don't like when the department gets new ventilators because they feel comfortable with the 840. By no means, when you graduate, have you learned respiratory care. You will be using equipment that is still in somebody's thoughts right now, 10 years from now. So once you get registered, you have not arrived. You guys will use APRV. I know what it is. I can explain it. I've never had the privy to use it. That's the way it is. So reps will come in. You guys may decide you want to be a rep. You want to work for an equipment company. You can do that. Most of the guys that come here that deliver our ventilators, or when we bought purchase ventilators, these and another one somewhere we own. That one over there we own. We had service reps come in. They were all RRTs. You can do that if that's what you want to do. Okay? Okay. Contamination is possible with inadequate cleaning. We don't have to clean it anymore, throw them out. Now, small volume nebulizers, the patient may keep it, but in lab, you will go through how you assemble and how you disassemble that equipment. If you drop the mouthpiece on the floor, on the patient's bed, it's contaminated. You got to throw it away and get another one. And if your patient is squeezing, you can't say, oops, excuse me, and have to walk back a half a mile to the department to get another mouthpiece. When you go on the floor to give therapy, you are prepared with everything and some that you might need. Do it one time, you remember. All you have to do is your feet hurt one time. You'll remember. Make sure you have everything and some if you're doing therapy that day. Okay? And that's where your common sense comes in. A wet cold spray occurs with mass delivery. Aerosol drug administration with face mask may inadvertently deposit in the eyes, resulting in eye irritation. A power source is needed for aerosol drug administration. You do need a power source. Whether it be at home, you got to plug it in, or whether it be a tank or disc. I guess that's a disadvantage, because if you don't have a power source, you can't deliver it. Okay? So you have advantages and disadvantages for everything that we need. Okay. Now, that's a small volume nebulizer. You don't need a power source with an MDI or a DPI. But the disadvantage of the MDI and DPI, if the patient can effectively follow instructions, the treatment is not going to be as effective. If we administered with a small volume nebulizer, either Dolores' little boy or Heather's little girl, they still got some. So you see, you got 6 in one hand, half a dozen in the other. It just depends. Does that make sense? Okay. So, I'm sorry, I didn't realize what time it was. So you can deliver SVNs, MDIs, and DPIs. So when we come in on Thursday, we're going to start going through Chapter 6, the short-acting beta-2 agonist. Okay. We're moving right into the drugs. You all have all the drugs for your drug cards. Workbook 1, 2, and 5 are due to me on Thursday. We're not going to put them up here. We're going to put them back there. Any questions? See you in the morning.